Hi, my name is Zach, and I suffer with obsessive-compulsive disorder, or commonly referred to as OCD. And from the start, let me say I'm not a doctor, I'm not a psychiatrist, a therapist, nothing like that. But I was diagnosed with OCD over 15 years ago, and I was experiencing my early symptoms before that first diagnosis. So I've got a decade and a half plus of treatment and experience to draw on, and I think that gives my voice at least some authority in this conversation. Um, I've been lucky in some ways because many OCD patients experience symptoms that are more severe than my own and that limit them more extremely. Still, my OCD does impact my life pretty heavily on a day-to-day basis. It has for quite some time. And I think what adds to the challenge I face and what a lot of other patients with OCD face is how foreign, alarming, and as much as I don't want to use the word crazy, some of the compulsive behaviors appear to an outside observer. There is always the option for a patient to try and explain, to bridge the gap of understanding by having a dialogue. But frankly, even in our current day and age, there's still a very strong stigma attached to a mental health diagnosis. That's especially true, though, when the diagnosis manifests with behaviors that seem very alarming and confusing. To a lot of people, seeing OCD compulsions acted out, it looks more like madness than a self-aware suffering. But the self-aware suffering is more often what it is. Not all OCD patients have a full appreciation that their obsessions are unnecessary or exaggerated and excessive, but most do. And that awareness is a particular distinction of importance here. It's really the difference between psychosis, which is often marked by detachment from reality, delusional thoughts, and potentially hallucinations, and neurosis, which is a marked state of distress and anxiety that impacts one's ability to function in very particular ways. Pretty clearly between these two definitions, OCD would fall under neurosis, not psychosis, which may seem like nitpicking, but is actually a rather crucial point. This is a big part of why I'm trying to make this video here, to voice some of my experiences and to help anyone that wants to learn gain a better context for understanding. I also want to note here that in the most recent version for the DSM, often referred to as the Psychiatrist's Bible, the DSM-5, OCD is noted as having a likely genetic component, at least a genetic component for predisposition. And the reason I mention this is that I've had a lot of people that I respect, admire, love, friends, family, coworkers, supervisors, essentially articulate that OCD is a matter of will, and that sufficient will should be sufficient to overcome it, that you should be able to fight your way out of it with strength of will. But with a genetic component being identified, that strikes me as ringing hollow. It seems very unlikely that this is just a matter of a bad thought process when they can identify sections of the brain that have certain OCD activity and when they have that genetic identifier. Again, perhaps I'm overstating this. I don't think the science behind that is definitive, but that was referenced in the most recent DSM, and that seems very pertinent here, especially to those who to my mind, diminish suffering by treating it as a matter of will instead of a matter of just forced experience. I'll go ahead and continue, though, to say OCD can manifest in a variety of ways. Let's see. Well, it's worth saying there is what's called a pure O version. And the pure O version is really kind of what it sounds like. Not carrying the compulsive dynamic, purely focusing on the obsessive side. Now, for my purposes, I'm going to speak generally and try and draw on some of my own experience because that's the best I know to do. But let's start by discussing obsessions. Obsessions are ruminating, intrusive thoughts. Now, it's not the patient's desire to have these thoughts. That's the nature of intrusive. They're experienced as unwanted and forcibly received. And they're very distressing, frankly. It could be thought of like a tinnitus of the mind or an incessant earworm. The core point being that for most sufferers, it's a near constant experience during their waking hours. And it's precisely this overwhelming feeling that leads to OCD patients acting on compulsions that at times can be detrimental to their own health. These obsessions, I should continue, can come in a variety of forms. Mine are mainly focused on contamination fears. That can be linked to a fear of exposure to filth or germs or just something that I associate with contamination. Bodily emissions frequently fit that category for me, which makes simply using the bathroom day to day a challenge at times. But they do also present in a number of other forms. Obsessions can include perfectionistic tendencies, fear of causing harm to oneself or others, sexual thoughts, and these may not sound particularly overwhelming or burdensome, I guess, when it's described briefly like this. But what I would ask anyone viewing this to keep in mind is that OCD sufferers, again, this isn't near constant. These are intrusive, frightening, unwanted thoughts. They're very distressing. And that's what leads to compulsions. Compulsions are ritualistic acts that are completed in an effort to try and calm anxieties produced by the obsessive thoughts. I remember someone once telling me that it was a bit like scratching an itch that won't stop, to the point that you're eventually clawing at yourself desperately, hurting yourself, trying to make it go away, but it won't. It remains, and in effect, the compulsive aspect, in this case described as scratching the itch, is becoming detrimental, but you just cannot stop. You are desperate to have that reprieve. And essentially that's what it amounts to, finding that reprieve from these intrusive thoughts. If giving in to the compulsive act is the only way to escape them, it does follow logically why most patients will give in to escape these unwanted, distressing feelings and thoughts. It's really the only way for many patients that they can try to live any kind of life, to drown out those intrusive thoughts. And the most recent version of the DSM also references that as well. When it describes the functional consequences of OCD, the particular points it notes is that a reduced quality of life is the most common functional consequence, but near seconds are reduced quality of life and then the follow-up of occupational and social impairment for second place. And that's frankly why it's really infuriating to hear someone say they're just a little bit OCD. The clinical definition of OCD carries a very specific definition, and the functional consequences of that are impacts to real parts of your life. It's not just about wanting to maintain your environment a certain way. It's about acting far in excess in order to pursue that, experiencing overwhelming anxiety and intrusive unwanted thoughts about that. It's not just making your desk organized a certain way, it's having a thought about that desk constantly interrupt your day, and feeling like you must go home and fix that desk for fear that it wasn't arranged properly the first time, which is kind of where it gets frustrating when someone who doesn't really have OCD is trying to claim that they have it just a little bit. Moving forward, though, what seems probably the best place to close here is to mention some of the most common methodologies for treatment. Again, not an expert, but from what research I've done and from what I've learned speaking to experts, professionals in my own treatment, exposure and response prevention, commonly referred to as ERP, is probably the most successful option. For many, it's probably also the most difficult option, though. As the name implies, it involves exposing an OCD patient to essentially items or scenarios that will trigger their compulsive needs, and then forcing them to not act. This is incredibly difficult because without I think it goes without saying, this is going to, for most, invoke massive anxiety to the point of panic attacks. It is something that's gradually built up to, so don't want to misrepresent it, but towards the end, it is extreme and very difficult. There are other methodologies used. I believe the most common option would be prescriptions. There they have SSRI antidepressants, tricyclic antidepressants, anti-anxiety medication, even rarely antipsychotic medication. I believe the latter being used mostly in treatment-resistant cases. Like ERP, though, it has its downside. I know it's fairly well known that most prescriptions, if not all, carry side effects, but this is particularly true over medications that are designed to alter the chemistry of the brain. This means that, in general, just about every medication they use to treat OCD carries notable side effects for most people when they try it out. These may or may not be severe enough to limit the continued usage, and honestly, for many, even if they do have detrimental effects, it may still be worthwhile because the benefits will outweigh the difficulties. But for many, some of these side effects can actually exacerbate their OCD. One of the most common problems to experience with all four of these types of medication would be stomach problems. Things like nausea, stomach pain, diarrhea. Well, if you experience contamination fears, as I do, with bodily emission being a compulsive trigger, that means that, in effect, many of the medications they prescribe me are definitively going to, well, at least quite likely, I should say, to cause these side effects. Most of the ones I've taken, and the ones I'm presently on at least, do. And I guess that's really the double-edged nature of the problem here. The treatment methodology for most severe cases are either prescriptions or ERP, along with talk therapy and likely other anxiety treatment methodologies, meditation, yoga, mindfulness, etc. But if these two primary methodologies also involve potentially creating additional problems as they're being introduced, it means that most patients that are going through this process are, in effect, experiencing potentially worse symptoms while they're getting better. The old adage that sometimes you do have to go through a rougher patch to get to the better place. And the reason I want to stress that is that when you struggle to articulate and speak openly about what you're suffering with because of the stigmas attached to certain mental health disorders, and when you're often told that it's a matter of will, something you can accomplish, or better, I should say, purely with effort, it's really, really painful to hear that from people that you greatly value, especially at a point when you need support and are going through very difficult treatment methodologies. For many OCD patients, even going through this treatment methodology, what they'll experience isn't so much losing their symptoms, but lessening them to a point of better functioning. It is possible to go into remission, certainly, but I wouldn't call that common by any degree, especially not for severe cases. For severe cases, it's more common for it to become increasingly manageable through treatment, which again goes back to the point. Those who try to articulate a view of beating this through will are really insulting people that are going through a very painful thing. I'm planning to try and make some more videos that are going to explain some of my personal experiences with my compulsions and obsessions in detail. But that's probably a good start for now. If anyone has questions, throw them in the comments. I'll do my best to answer, but try and be respectful because, honestly, it's not always easy.